right. Well, welcome everybody to another edition of Zooming In. We have the pleasure today to be speaking with Dr. David Goldfarb, at the Chief of Nephrology at the New York Harbor VA, and also Clinical Chief of Nephrology at NYU Langone. So, David, thank you very much for joining us today. I really appreciate the time.
Thank you, Michael. I appreciate you, and I appreciate, of course, Outset Medical supporting us the last couple of weeks.
Thank you very much. So, David, I still think as the COVID situation continues to progress, I think a lot of our information is coming from media and political outlets, and so I think from a physician-clinician standpoint, I think we'd really like to know kind of how things are going in New York right now. What's the situation? Are we seeing the curve flattening? So if you could give us a little bit of insight, I think it'd be fantastic.
Yeah, the curve on hospitalizations and intubations has gone down a little bit. Of course, because we're representing major medical centers, that we're still experiencing lots of patients that need dialysis and seeing lots of patients who are in the ICUs. But there's a lag. The patients get infected, and it takes about 14 days before those patients are critically ill. So we do think that the number of new admissions going down is going to turn into fewer patients needing dialysis, but we've still got a bunch of AKI to take care of. It seems a little bit simpler today because we've had a couple of fewer everyday emergency room admissions, and so we're sort of seeing that light at the end of the tunnel. I think I told you earlier that the New York VA has been taking non-veterans for the first time in our history, as far as I know. And that means we'll continue to take patients from hospitals that are overwhelmed. So it's not completely clear what my personal response here as this continues.
Right. And David, what is that kind of, how long are these ICU stays, or how long are these patients in the hospital for? I think that's something that hospitals preparing for a surge need to kind of calculate in is kind of what's the expected admission for those critically ill? What window are we talking?
Yeah, and there's obviously a gigantic diversity. Right. There's a lot of patients who have come in with AKI and have actually gotten better in a relatively short period of time. Maybe those patients had some pre-renal volume depletion, that sort of thing. And so we have seen patients get better. We've had a couple of patients who started dialysis and then got off. But right now we're dialyzing some people who have been in the intensive care units, intubated for 2 weeks or more. So it's been extremely variable. And then the people who get AKI on ventilators are having prolonged course.
Right. And are you seeing a lot of renal recovery for those that are getting better and leaving the hospital? Are they leaving recovered, or a lot of kind of prolonged AKI and outpatient dialysis needs?
Yeah, I mean, and again, of course, you can imagine there's two groups. There are patients who had normal kidney function, and most of those patients are getting better and not being dialysis prone. Dialysis requiring when they get discharged. And we have some CKD patients, and of course those patients, often come under the heading of the risk factors that have turned out to be important risk factors for bad outcomes, like even hypertension, diabetes, and overweight. So those are patients who, started out with creatinines of 3 or 4 at baseline, and it's looking like some of those patients will remain dialysis dependent when this is over.
Yeah, no, thank you for sharing that. I think we've had a lot of questions about that in terms of expected recovery. We've heard a lot in the past few weeks from other physicians, as well as on the news media sources, about shortages of supplies, staffing, devices. From a nephrology perspective, what were the big resource shortages for you? How did you solve those resource shortages, and what's still ongoing, or what are still some ongoing concerns as you keep caring for patients here?
Yeah, so of course, nobody ever anticipated that there could be an epidemic of kidney disease that would lead to running out of stuff. The first thing we ran out of course, was staffing. And I asked you about tableaus. Do the machines come with a staff member? Because that really, we lost people. My head nurse was out, tech was out, a nurse was out. I have a nurse with kind of a chronic mild neutropenia. His doctor told him to go and stay home. So we really lost the ability to do as much dialysis. And here at the VA, I have an outpatient based 45 hemodialysis patients. So I have to take care of them as well as the patients that got admitted to the intensive care unit. So that really the first issue was staff. And we're still looking for volunteers. I filled out a a thing on the American Nephrology Nurses Association website looking for people to come in. So that's one issue. And I'm still down a nephrologist, and I got Dr. Clay Block came from the White River Junction VA as a volunteer. He's just been a lifesaver for me for 3 weeks now. So that's really important. The next thing was, excuse me, the next thing was we had to get into find ways of dialyzing all of these people, because if I am short on staff, I can't do bedside hemodialysis for everybody. So we, and at this hospital, unlike at NYU and Bellevue up the street, up First Avenue, I have not done CVVH for a variety of reasons, mostly because I did not think we had enough cases to really develop expertise in that. So the next thing that really we got into was doing acute PD. And 3 or 4 weeks ago, I said, when people said, let's do acute PD, I said, nah, it's never really going to be efficient enough. But we had no choice. We moved to PD. Then we ran out of PD fluid. And Baxter has been great in trying to keep that supplied, but we're never quite getting as much as we need because the demand in New York City is so tremendous. At Bellevue and at NYU, again, they were also using gigantic quantities of PD fluid. The other thing at those two hospitals, they do a lot of CVVH. So there were short-lived shortages, but they occurred of cartridges to use in the PrismaFlex machine, as well as shortages of CVVH fluid. So those were things where everyone in New York is trying to get that stuff supplied to them in copious amounts, and we're not competing with each other exactly, but there's a limited amount of that stuff. So I think fortunately we have not quite been on the verge of running out of anything that led to people's deaths. It's been frightening at times.
Yeah. And anything ongoing? It sounds like some of these supply issues are seeming maybe at a balance or kind of we're at least keeping up with demand. Is that still kind of the case, or what seems to be the ongoing concern?
Yeah, I would say that staffing remains an issue. People missing work, and some of those people are just exhausted. I rather than simply having COVID infections. And then I think we're having a supply today of PD fluid, of Dianyl. We're switching to a couple of cyclers as well, and that sort of helps us. But this isn't over yet, and exactly how this will go in the coming couple of weeks is not clear.
Oh, okay. Well, no, thank you for that. One kind of question. I mean, obviously, you've been in the midst of this now for an extended period of time. Going forward, kind of what have you kind of learned from this experience? What could you share for other programs? These surge events don't normally happen in these big national and international scales, but in smaller regional scales, there is always that need for surge capacity and the ability to deal with a higher patient load at any given time. So kind of how does that maybe change the structure of your dialysis program going forward, or what learnings have you taken away from this experience that you think will maybe help you be a little better prepared for these kind of things, should they happen again in the future?
Yeah, I think those are important questions, and I'm not sure that I don't know whether the ASN, NKF, RPA have really thought about the answers to those questions, because we've lived through Hurricane Sandy as an example. Wrote about it. We dealt with the disaster of having our dialysis unit closed for 5 months. And, fortunately, no one died as a result. We were able to move to the Brooklyn VA at that time. So our planning for disaster has mostly been telling our patients, stay home, don't eat a lot, don't drink a lot, and we'll see you in a couple of days. And, of course, that didn't work out for Hurricane Sandy. So what exactly we do in terms of finding other dialysis units to help us, that was certainly possible after Hurricane Sandy. We called local private dialysis units and got all of my patients dialyzed. We set up a little dialysis unit at the Brooklyn VA. It seems simple in retrospect, because at this moment, all of the private units, the large dialysis organizations in New York, they have their own staffing issues. People lose staff, and having dialysis patients not wanting COVID positive patients to come in and mix with the COVID negative patients. Everyone's trying to cohort the patients separately. So it's really complicated. The other thing that we highlighted in the article that was in the New York Times on Sunday, and we have a paper coming out in See Jason tomorrow, where we describe all of these shortages. We recognize that there's something called the National Strategic Stockpile. They have ventilators. And obviously the president and the governors of the states have talked about ventilators. We've been amazed that no one talked about dialytic supplies and how to take care of all this kidney failure. So, should there be a reserve, a national stockpile of dialysis machines, CVVH machines, catheters, and that sort of thing? Obviously, some of these things have expiration periods. The other possibility that we've thought about is, should there be a plan for manufacturing things that, if the General Motors can make ventilators, are there organizations that can make PD fluid or CVVH fluid? Should we think about that as an eventuality, that under these kinds of circumstances, it wouldn't simply be Baxter and Fresenius manufacturing fluid? So I think that's an interesting idea, and obviously way over my pay grade, but these are the sort of complicated things that I think the nephrology community should contemplate.
Right. And anything locally at your facility or in the way you deliver care that you think you could make a modification going forward where you might be a little better able to handle something like this? Again, you don't want to expect it, but always important to plan.
One of the things, of course, I'll just say, I'll use that opportunity to tell you that using our tableau machines clearly helped because we were able to use them pretty quickly, figure out how to use them. That I did my own dialysis without a nurse for last week for the first time. And so that sort of was a way of extending the staff. We've got people who previously did not know what dialysis was, had never been in a dialysis unit, using the tableau. So, there's a learning curve, of course. You still have to learn how to use it. But we have been able to take nurses in our hospital from primary care. They don't have much to do right now because we're not seeing outpatients very much. We're doing a lot of telehealth and telephone calls. So taking workers, nurses, and techs, and being able to train them to do hemodialysis using a tableau machine has really been another way of us extending the ability of the dialysis unit to help. It's also kind of, as I told you, we haven't done CVVH here. So we're doing a couple of, let's call it accelerated veno-venous hemofiltration, using one tableau machine for 8 to 10 hours to do a longer treatment, and then getting 2 people done with one machine, and being able to do it kind of off hours when my hemodialysis nurses would normally not be here.
No, that's great. I think it's important for all of us. Again, there's areas of the country not being affected as much by COVID, but the idea that there may always be surge capacity and kind of planning for that. David,
I think I'm sorry, but one of the goals of writing the C. Jason piece that's coming out tomorrow or talking to the press has been to warn our colleagues, around the country, that if there's going to be a surge elsewhere, as New York, I hope, stops being the epicenter, but we currently have no effective treatment or vaccine. You sort of have to think about this now, really consider, exactly how much dialysis you can do, how much CVVH you can do. Do you need to acquire new machines today, and how's your staffing? And be thinking about this in a way that certainly a month ago we could never have anticipated.
Right. No, and I appreciate that, and thank you very much for those insights. Well, David, we really, really appreciate your time. I know you're very busy. Thank you so much, and look forward to talking to you soon and seeing that curve flatten and hopefully allowing you to kind of get back to a little bit more of the usual circumstances going forward.
Yeah, like go back to being a kidney stone doctor.
Right.
Mike, I appreciate your time and your support as well.
No, absolutely. Thank you very much. Take care and stay well.
Take care. You too.
Bye-bye.